Next, I'm joined by Dr. John Ormiston, Associate Professor of Medicine at the University of Auckland in New Zealand, to discuss bioresorbable stents. John, welcome to ACCEL, and tell us a little bit about some of the fundamentals of bioresorbable stents and why they might be the next generation of stents.
I think the first question is perhaps why would you bother with a resorbable stent? And in the surveys of cardiologists almost universally would prefer a bioresorbable stent if all else is equal with a metallic stent. And patients certainly like the idea of a device that does its job and goes away. And especially Asian people from China and Japan, very keen on the idea. Apparently Confucius said that your body is given to you by your parents and you should not do anything to it like cut it or leave stuff in it. So there's a very strong desire not to have a permanent implant in China and Japan. It may be that if you have a normal healed vessel, you won't have trouble with late stent thrombosis. If there's no foreign body and the vessel's healed normally, then there may not be late stent thrombosis. With resorbable stents, the vessel is no longer caged, so it can expand and contract according to physiological need. And also there's increasing evidence that to be healthy, a vessel needs to be exposed to pulsatile and shear stresses. Otherwise, it's not a healthy vessel. And with a resorbable device that looks like it's going to be possible again. And if it's a normal healthy vessel, there may not be the late neoatheroma that we're seeing with metallic stents, which is one cause of late stent thrombosis, is new atheroma forming within a stent that can ulcerate and cause thrombosis. We're also seeing that the vessel can expand a little after the device is absorbing, so that if there were new atheroma, it can accommodate like that in a Glagov way. And we know that a little bit of vessel expansion is possible. We've seen that in the latest trial data from the Absorb Cohort B1 trial, where the device is still visible, but it gets bigger between 6 months and 2 years, and the vessel itself gets bigger between 6 months and 2 years. So although there was some intimal hyperplasia, the lumen got a little bit bigger, in contrast to metallic stents where the lumen gets smaller because obviously the metal scaffold can't expand. It gets narrower because there's build-up of intimal hyperplasia. So I think that's very interesting. Also, imaging with MRA and CT is unimpeded, well, a polylactic bioresorbable scaffold anyway, so that you no longer have the artifacts you get on these imaging technologies. We're getting interesting information coming through on side branch jail. If the side branch is covered by struts and then the struts absorb, then it may be that side branch jail goes away with time as well. Strut fracture has been a cause of restenosis with some of the earlier generation metallic stents. If the scaffold goes away, late strut fracture is not going to be a problem. Also, maybe revascularization, if necessary, may be easier if you don't have a full metal jacket. So I think those are some of the major reasons why we might like to have a resorbable scaffold.
I think in terms of the physiology of the coronary arteries, I mean, if at some period of time after stenting of a lesion, that endothelium is restored, the subintimal areas begin to restore themselves to their normal anatomic structure. This could be the ultimate promise of going back to the blood vessel of a 20-year-old, because it really does remodel the entire vessel, not just the lumen. Tell me a little bit about what the stents are. What are they made out of, and what is the absorption characteristic?
Well, the one that's had the most study is the BVS from Abbott, and it is constructed from polylactic acid, and it has a coating of polylactic acid and everolimus. So the struts are made of polylactic acid, and they metabolize to carbon dioxide and water, which are obviously natural products. And polylactic acid has been used for many, many years in the human body as like resorbable sutures, orthopedic plates and screws and things. So it's not some kind of weird material. The body knows how to deal with this. Now there's another approach that is the magnesium device. So they make stents made of magnesium, and magnesium is absorbed pretty quickly. These so far have not been very successful because the resorption time has been too quick. So they haven't opposed the negative remodeling forces that the major cause of restenosis after balloon angioplasty. They have tried coating the magnesium stent with an antiproliferative drug to stop the neo-interval hyperplasia that occurs with stenting, but still the restenosis rate and the late loss has been higher than is acceptable with a contemporary stent. But if they can delay the resorption of the magnesium stent, then it may work.
So deploying a bioresorbable stent, I mean, from the physician standpoint, it's going to look pretty much like any other stent in terms of the way it's deployed with the catheter and the mounting on the balloon and things like that.
Yes, well, the BVS, it's a balloon expandable device. It still has some limitations. Its crossing profile is somewhat larger than a contemporary metallic stent. It's 1.4 millimeters, whereas a contemporary stent would be like 1.1 or less millimeters in crossing profile. Also, it behaves in a different way from a metallic stent in that if you have a strut malapposition, you can't just keep dilating until it opposes the wall. Because if you try that, you may fracture the polyelectric struts. So we have to be very careful with sizing of the device to the vessel size. Many of us are now doing online QCA so that we can be sure that we're not putting it in a vessel that's too big for the device. So this is a difference from conventional stenting.
This stent's been in use in the experimental process in patients for 4 or 5 years now, I take it. Is that right? So what have some of the early clinical studies shown in terms of restenosis rates and the disappearance of the stent and so on?
In the Cohort A trial, at 5 years, in 30 patients, there was only one MACE, which was a non-Q wave MI, which occurred early on. So that's really good clinical results. But this early device did absorb a little too quickly so that there was scaffold shrinkage and higher than optimal late loss of about 0.4 millimeters at 6 months. And then, interestingly enough, the lumen got bigger by 2 years. So that was a very interesting finding. So the device has been changed so that its design gives more uniform scaffolding, and in addition, the polymer has been reprocessed in a different way so that it lasts longer in the tissue. In the Cohort B device, the late loss at 6 months was in the order of a sirolimus-eluting stent, and it's really interesting that between 6 months and 2 years, there is slight luminal enlargement in the Cohort B device because the struts of the scaffold get bigger. The lumen gets bigger because the struts area gets bigger and the vessel itself gets bigger. So this small positive remodeling is not possible with a metallic stent because a metallic stent cages the vessel. So it's looking very, very promising.
It sounds very good. At what time do you think? About 2 years there would be no evidence of the stent at all? Or
in the Cohort A, the stent was largely gone by 2 years, but with the Cohort B device, which lasts a bit longer to give better radial strength at 6 months, it looks like it's going to be absorbed much more slowly. It may be 3 or more years even before it's completely gone.
I think you mentioned that when you look at the physiology of the coronaries, the expandability of the vessel during pulsatile flow, the shear forces that vary on the endothelium in a normal vessel clearly don't get restored in a metallic stented vessel, and this promises to pretty much restore the normal physiology of the vessel in that area, which I think is an interesting thing because so much of that plays into the long-term health of the vessel and endothelial function. Some of those things we don't even understand, but clearly getting closer to normal physiology after a couple of years of stent would be desirable, and it sounds like we're approaching that.
Well, that certainly is one of the hopes that this device will provide.
Well, thank you for being at ACCEL. I think that this is an important area. I think we're going to see more of the absorbable technology coming along, and I think some of the early studies are suggesting that we can restore normal physiology as well as normal anatomy of the vessel, which will be an exciting new thing to do in the future.
Thank you very much.
Thanks again.